Respected Chair, teachers and friends, good morning. I thank the organizers for inviting me here and on behalf of my team. So transplant immunology as well as disease donor transplant is actually evolving in our country right now. And I would like to narrow down my discussion to 2 points. Basically, the utility of this test from a clinical decision-making standpoint and how to address as a community to facilitate transplant for our sensitized patients. So in pre-transplant testing, nothing is black or white, and what all we are finding is just the preformed antibodies. You don't have any magic wand to diagnose what your memory response is going to be. And for a wait-listed patient, his immunological status is going to be, labile. And coming to the scenario in India, we all know that it might take a little more time for us to have a histocompatibility-backed organ allocation. But I think as duty-bound physicians, we are bound to show maximum justice to our patients with the current tools that we have, especially in transplanting our sensitized patients. So antibody testing is highly contextual. When a patient walks in to be waitlisted, you can screen him for any anti-HLA antibodies, and if we have one, we can do a single antigen bead, look for donors. At the end of the day, when a transplant is offered, we can look whether there is a donor specificity. But having an antibody or a donor-specific antibody does not preclude transplant. At the end of the day, the decision-making is done by a cross-match CDC or flow. As a practicing physician, we should be aware of the cost involved and the turnaround times in these testings that we have. But in 2024, as we stand today, a region which does disease donor organ transplant should have these basic 4 facilities. They should have a validated flow cross-match facility. They should have a Luminex facility to screen and to do SAB for their patients. And you should have a basic HLA typing facility, SSP or SSO is good enough, and 2 resolution, low resolution, intermediate, anything is good enough. Flow cross-match outperforms CDC in all fronts. So on a scientific basis, there is no legitimate reason for us to stick on to CDC cross-match anymore. It is for a disease donor setting, it's a very less turnaround time. You don't need live cells. It is very objective. You can share your data, and it is semi-quantitative where you can have some sort of a reactivity pattern also assessed. Luminex is nothing but a modified flow cytometer. It depends on what sort of a bead you feed this thing. The usual beads that we use here are the screening bead and the single antigen bead. The screening bead, the most common HLAs are stuck onto few beads, and it gives you a qualitative report. It's very appreciable. If the antibody is not there, then it is negative. Similarly, different flavors, it can come class 1 positive, 2 positive, and the last one in the right lot of quadrant, it is both positive. So we had 600, in North Carolina, we had like 1,644 NGS high-risk type patients. And at the serological, we cross-checked with both the vendors. They have 100% representation. So it is pretty satisfying that, all our serological level, both vendors have representing this screening tool for us. And it has got some sort of a congruence with the single antigen bead data, as is appreciable in this picture. And another thing is that it is somewhat cost saving. If your screen is positive for only one class, you can land up with doing just SAB of that class, which can save a little money. Coming to single antigen bead, I think we all are aware of it. Each bead is one antigen, and at the end of it, you get an antibody profile that this patient has so many antibodies. But the critical thing is that how to tease out a clinical decision making from the SAB data that is flooding. Okay, so people have looked into cutoffs. Okay, it is basically a vendor-driven cutoff. A, B, DR, and DQs are the most important lockers, and we have pretty much globally have come up with a setup 1,000 to 2,000 MFI. But C and DP are not physiological beads, they're like supraphysiological, supersaturated beads. We have given some sort of a liberty in having their cutoff 2,000 or 3,000. But that is, these are papers from, this is from Professor Terasaki's lab, and others from Opel's lab. They're giant labs as far as transplantation are concerned. 30 to 60% of unsensitized male are having this single antigen bead positivity, and and it is that cannot be ignored. we all know that is irrelevant clinical information. So with this flooding of information, how can you transplant a patient? So MFI goes back, and you have to look for reactive patterns, which takes the upper hand. And though we are like 200 people here, each one of us will have a different HLA, meaning that it is highly polymorphic, but among HLA there is a lot of homology. So when you develop an antibody against an epitope, these epitopes are shared by different groups. So suppose you get an antibody profile like this, you know that it is impressive. But when you translate into how sort of a correct behavior it is, it falls into a A2 correct. In that correct, each antibody is equally important. Whether it is 500 MI or 50,000 MFI, you have to avoid that A2 correct. You have to have a donor outside this group. Another strong reactive pattern is the BW4, BW6 pattern. Any HLA-B will have either a BW4 jersey or a BW6 jersey. It is just like a public epitope. Unfortunately, if a recipient develops an antibody against BW4 epitope, the whole BW4 who has that common epitope will be hostile to. So he has to have an organ from a BW6 donor. So the thing is that, so you have to look at patterns. And with the current evidence, HLA-C and DP has no role in the, and many of these US centers and Western centers have stopped reporting C and DP antibodies because there is no real data to show there's an impact on long-term outcome. So at the end of the day, again, you know that pattern is better than an MFI value. But as a clinician, you have to take a call. People have looked at the different angles to this, how important it should be. And at the end of the day, the flow cross-match trumps everything. If you have a DSA, unless and until it lifts up in flow, you can facilitate a transplant. So it was way back in 2013 that some sort of a guideline came in histocompatibility. At the end of the day, what they told was that you have to have a cell-based cross-match, either CDC or flow, then you have to test that in Luminex platform. So in 2024, flow cross-match is the way forward so that we can adopt. So this was a good study done from Delhi. It was a prospective multi-center study where you had to look at the blue columns, the sensitivity of each test. CDC was only sensitive in picking up 12% of these antibodies, whereas flow was able to pick up 85%. So when you add a HLA antibody screen also along with it, see that the first blue club is almost 100% sensitive in identifying these antibodies. So this is where we have to start. Any waitlisted patient will have to undergo HLA antibody screening. And if it is negative, then we are good. Irrespective if you are doing a CDC or flow cross-match, it has to be negative. That's the current understanding. Okay, now that problem starts. Now let us see an intermediate group, which is the screen has shown that there is some HLA antibody activity. Now you have to do a single antigen bead at that point. So you get a profile, you have to look at the MFIs, you can have a feel whether it is a strong reactive pattern, and you don't have a donor rate there to look for DSA. So the challenge you have in the lab is to predict how the cross-match is going to be on the day of the transplant, because you have a very limited time to mobilize your resources. So there comes the role of surrogate cross-matches, okay? So any lab can help you out. We are a primarily living donor program in India. 85% of transplants is living donor. All HLA labs have a lot of data out there. So if you have a A2 correct pattern, the lab, you should talk with the lab, get hold of some guy with homozygous with A2 or have a A2 profile, do a cross-match and see. You have ample time with you, okay? So the topmost patients should be done some sort of surrogate cross-match profiling, and if they are negative, on the day of transplant, the cross-match is bound to be negative, and you can go ahead and do a transplant. So this is the data way back this is from the Paris group, way back the CDC era. So these patients were transplanted with the CDC cross-match negative at that time. And if you look, they had done the DSA in a retrospective way because they had the day 0 serum. And what you see is that, of course, the DSA people did not do good. But at the end of the day, had it been a flow cross-match, the graph would have been different. But still, if you look at them from a pan-Indian scale, if you look, 60 to 70% of the transplant patients had a graft survival of more than 6 years, which is not that bad from a pan-Indian perspective. So this is one of the patients that we transplanted 10 months ago. We don't have a robust disease donor program in Kerala. So this patient, this is a 20-year-old kid, strong positive class 1. We did a lot of surrogate cross-match, which was persistently negative. And one day he got an organ, the cross-match was negative, we transplanted it. And retrospectively we looked for a donor-specific antibody. So we transplanted him with a donor-specific antibody more than 10,000 MFI. but the cross-match was negative, okay? And, sorry, I can just change it. No, actually this is, you have to, it is not moving. Okay, got it. So now coming to the third group, that is actually the problem child, okay? It is that you have that cross-match, you have the DSA positive, it has a dangerous pattern, your cross-match is, your surrogates are positive, and your cross-match is positive. This is where, as a society, as a transplanting community, that we have to find a solution. So you have to have a compatible allocation, unless and otherwise we are not going to transplant this population. So this is actually our data from North Kerala. This is our typing data. So if you look, the way, this is the spread, okay? So if you see, in each group, almost, just 30% of the HLA antigens are accounting for almost 60% of the patients, okay? So if you have a A2 and A24, you are denying 60% of your donors. Same with DK. So this is an opportunity as well. You might have donors who have other those HLAs which are not that common, but unless and until you have a bigger pool to allocate, we will not get it. For example, this is the patient who is waitlisted in Kerala for the longest years. He was waitlisted in 2012. So she has got all DR against her own DR, which is DR7. So she has to get a DR7 homozygous donor. The chance of she getting is just 2%. So unless and until we have a broad-based allocation system, she's not going to get it. So the Europe people did it long back, So almost 30 years ago, they did not have Luminex at that time. So what they did was that they fixed the acceptable mismatch program for highly sensitized patients. So they allocated just on DR matches, okay? They fixed the class 2. Class 2 is one thing that is more detrimental in the more important long-term outcome. So once they fixed the class 2, they used to tease out with class 1s. And if you get a class 1 negative, they just went again and did a transplant. And if you look, 80% graft survival, 10-year graft survival. This is very impressive data, okay? So what I think that futuristically, 70% of our patients might be, we can get away with a local regional allocation in your area, In Kerala, there are 3 regions. But, that 10 to 20% people should be siphoned to a special program where you have either a statewide or an interstate allocation system. So to conclude, we all have to agree that flow cross-match should be our final gatekeeper for disease donor transplant. SAB data is, you have to apply it. It has to pass through the filter of what we've discussed, and especially the final gatekeeper would be a flow cross-match. And the last, but no, the most important is, for this sensitized patient, as a community, we have to have some sort of hand-holding together. Otherwise, we are not going to transplant this patient. So our priority should be to transplant this sensitized patient rather than allocating a 0-MISA 6x6 antigen to a patient far off. I thank my mentors and thank everybody for giving me this, whatever I have learned is from these people. Thank you.